Good evening, everybody. Welcome to the Frontline Club. It's a real honour to have Gino Strada and Giles Duley with us this evening. Before I hand over to Giles, if I can just get you to switch your phones to silent. And when it comes to questions at the end, if you can say who you are and wait for the microphone because we are broadcasting live. Over to Giles.
Could somebody... So when I was downstairs, and I thought it started at 7:30, and I was kind of thinking, not many people have turned out. It's upstairs. Hi, everyone. A few years ago, I was working in in Sudan, just outside Khartoum, with Emergency, documenting the hospital, and I had the good fortune of meeting Gino Strada, and really, as soon as meeting him, I felt he should come to London and do a talk and come over here. As you'll probably find out through the conversation, Gino's not always the easiest person to persuade to do something. And I think I had to get blown up before he was kind of persuaded he might come over here. I wouldn't say it was worth it, but at least there's one benefit. Now, obviously, I'm a photographer. And so suddenly to be sitting here trying to do some kind of interview is going to be a bit of a nightmare, a bit of a disaster. So I thought I'd get really, really prepared, and I downloaded every kind of interview I could find on Gino and did the biography and did all the rest of it. I was going to sort myself out with lots of questions, etc. And then at the last minute I suddenly thought that was a complete waste of time, because really what I want to talk about tonight is more the philosophy of Emergency and Gino Strada and the reason why he does the things he does. It's not going to be a formal interview and questions about Gino's life as such, but more the reasons why you do the work you do and why you feel it's important, and also hopefully bringing up some of the questions that I've certainly encountered in my work with Emergency about why certain things do not happen. For example, the lack of hospitals in Afghanistan. So here are my notes. I'm just going to get rid of those. But I have got this one page here. When I was in Sudan, I said that was about 3 years ago, and I used to email to my now girlfriend, who wasn't my girlfriend then. I used to send her these long emails. I think I was just trying to impress her, so I tried to make them sound like I was living in very dangerous places and doing very exotic things. And I sent her one when I was in Sudan, soon after I met Gino and when I was working at Emergency. And I found it again today, and I just suddenly thought, in some small way, it's relevant. So excuse the kind of slightly exaggerated prose, etc., but as I say, I was trying to make her my girlfriend. And let me just... so if this is slightly self-indulgent, my apologies, but as I say, hopefully it will set the tone a little bit. It's midday here. The sun is high and still in the dusty air. I'm sat at the small wooden desk in my room. In front of me is a large window. A panoramic of the Nile stretches before me. A large stork prowling its banks. A small fishing boat drifts slowly by. Even its pace seems slowed by the stifling heat. Gino Strada sees this hospital as a statement of solidarity with Africa. He wants to show that a child in Africa would get exactly the same treatment as a child in Italy, not just to be saved, but to receive the exact same level of care and attention. To him, there should be no difference in how you treat people, and by doing so, you show we are all the same. Of all his projects, the Salam Centre seems to be the embodiment of this philosophy. It's a beautiful building where function and form sit in unity. A simple structure built to shade a window does not have to be a sheet of corrugated iron. It can be a woven structure of bamboo that stands like a sculpture in front of the hospital. The corridors are wide, light, spotless. The wards have only a few patients per room. The staff, a mixture of Italians and Sudanese, are courteous to a fault. As one old lady said to me, they treat her as if she were their mother. I've never been in such a perfect hospital in Europe. And on each day, the team of 4 surgeons rotate to do a minimum of 6 life-saving operations. Gino greets me in the corridor this morning. He's leaning on the wall outside the operating theatre. Much to the nurse's annoyance, he has a cigarette in hand. Nobody would dare smoke in this hospital, but it's Gino. It's a factory, he says, shrugging his shoulders before going back to the operating theatre. But that is his way. What Emergency has created here is something truly special, and when you see him operating, his passion is undimmed. Whilst on the surface, he seems tired of all he's seen and somewhat cynical. Inside, as a surgeon and a humanitarian, one feels he will never relent. So I sit in my room, wondering how to capture this essence, this philosophy. Hospitals are such hard things to photograph. By their nature, they are sterile, the light is flat, the conditions controlled. They do not lend themselves to my photography. Before I came here, I knew this would be the challenge. So I sit here now, trying to visualize what I will create. In the 2-3 weeks I was there, I was unable to take that picture. I took some photographs that I will show you later, but I was unable to capture the photograph that in my mind made Emergency stand out from all the other NGOs I've worked with. It would be nearly 3 years later, when I was back in Afghanistan, that I would finally take the photograph that I think in some small way encapsulates the philosophy of Gino and the philosophy of Emergency. The fact that they are not just hospitals built, but these are places, oases of calms. I took this photograph of the hospital in Kabul. And as I say, for me, it was an embodiment of much of what Emergency stands for. That in chaos of war, in conflict areas, the emergency hospitals stand as testament not just to the amazing doctors and staff that work there, but as a statement saying your level of care should be exactly the same as the level of care of somebody in Europe, that we all are equal. Well, I'm going to continue now by welcoming Gino to London at last.
Thank you very much. Good evening, everybody. It's a pleasure to be here, really. I'm not very much keen to go around and give talks, and because I'm getting old and I'm tired, and I try to save all my energies for the operating theatre. But you said very important things, such as that establishing a hospital is a great opportunity to show people they can be treated as human beings equal to each other in dignity and rights. And that's what we tried to do at the Salam Center. Is not to stress the work of Emergency, but to be honest, I've never seen a hospital like that in Italy either. And it's not a joke. I mean, I never seen a hospital that clean. I never seen a hospital. When I say clean, it's not a matter of aesthetics. A clean hospital saves lives, much more than a good surgeon. Because most doctors tend to believe that it is their knowledge and skills that eventually, determine the outcome of the patients. It's not true. Many patients are lost, and many lives are lost worldwide because treating facilities are not clean. The problem is that you don't see the one who dies because of an infection directly connected to your work. So you don't think, well, it is my fault because I didn't wash my hands that patient died. And it's a bias. I've never seen hospitals where people are treated with humanity, a bit of compassion maybe, some solidarity, professionalism, which is exactly the way that people should be treated, because hospitals are a strange entity, actually. It's probably the best lens to look, to focus exactly on what and which kind of society we have in front of us. Hospitals where patients are not patients anymore, but are clients. I mean, we don't want to have anything to do with that. And today, what to me looks absolutely trivial, that healthcare should be high standard, open without discrimination to everyone in need, and free of charge, sounds somewhere between revolutionary and utopic. It's not. I mean, it's the way it should be for the simple reason that all of us, sooner or later, will be in need of medical and surgical care. And since this is the reality, I think the best solution is to have it free of charge for all and excellent quality for all. But to speak about these issues today is not so easy. We have started many, many years ago. Now it's more than 19 years that emergency was established. And we decided to establish an organization to treat victims of war, knowing perfectly that whatever you read on the newspapers or listen to on the TV programs, over 90% of the victims are civilians, with very, very few exceptions, and small conflicts for small periods of time. But in general, this is the rule. 90% of the victims are civilians. And for these people, there's almost nothing in terms of medical and surgical care. So emergency was born with this idea in mind to provide, support for the victims of war. Many of us that started emergency had previous experiences with the International Committee of the Red Cross in Geneva.
I mean, if you don't mind me just going back to actually how you even got into that route. You studied in Milan.
Yeah, I studied in Milan. I graduated in Milan.
And initially was heart and transplants and...
No, I started with emergency surgery. Then I was interested in transplant surgery, and I spent 4 years in the United States, mainly focusing on heart transplantation and lung transplantation. Very narrow fields that sometimes are quite misleading because you don't get exactly 360 degrees the perception of what the medical needs of the world are. But when we started emergency, that was our focus, the victims of war. And then over the years, we realized that you don't have to be hit by a landmine or a bullet or a shell to be a victim of war. If an entire population cannot have, safe pregnancies anymore, or if children die for very preventable diseases just because war has destroyed the little infrastructure that existed in medical terms, well, then the population as such is a victim of war. And so we started to expand our activities to maternity, to pediatrics, to rehabilitation, without forgetting where we started from. And today we are, still present, as you know, in Afghanistan with 3 surgical centers and 34 clinics, I think, or 33, something like that. But we open one every month, so I lost counting. But at the same time, we have this beautiful center for cardiac surgery in Khartoum. And again, this is a scandal. I mean, we are talking about globalization, about the international community and all these strange concepts. And then you have a continent, and in the entire continent there's not one hospital. Well, there was none before the Salam Center was established in 2007. Not one hospital where you can have cardiac surgery free of charge. It's unbelievable.
Maybe I'll just show this was actually a photograph I took before I'd ever visited the emergency centre. I was in Nigeria and witnessed the process of going through various patients that were coming to see who could be shortlisted for possible surgery at the Salam Center in Sudan. And I have to say, it was one of the most upsetting things I've ever photographed, because people had travelled all across from Nigeria to come to the capital with children who had heart defects. I'm sure Gino will explain more about the types of problems they have, but the desperation in all these families, because they knew there was no other option. There is nowhere else they could go for help. And obviously the Salam Centre is just one centre in the whole of Africa, so the numbers that they can take from each country are incredibly limited. And to see this child was being tested, and unfortunately the child, for various reasons, wasn't fit enough to travel for the operation. And to see the mother's face, who had literally walked for days and days to get there, and be told that unfortunately they could not take the child to Sudan for this operation, and literally her screaming that there was no other option, and having to then leave and walk back. You know, that was really, for me, such a tragedy, because it was something where you knew there was a solution, there was an answer. This person could be helped. I then went to see for myself the work that was being done at the Salam Centre, and you know, here's a photograph of really, I guess, a very normal representation of how many of the patients are when they turn up. Many unable to walk, unable to play, unable to live normal lives. And as I say, with no other place they can go, they travel from all around Africa to go to this centre. And just kind of remember that face. This is one of the kids waiting for an operation. I have to say, I remember I took this photograph actually a few months before I was injured, and I think I had this expression quite a few times myself. And here is Gino at work. I think actually this is the first time I met Gino. Busy working. And here some of the heart surgery. I have to say, witnessing heart surgery is one of the most fantastic things I've ever witnessed. It's a kind of combination of artistry, of skill of a craftsman. There's a certain amount of arrogance that seems to go with the heart surgeons as well, but all those things combined is just one of the most mesmeric things I've ever watched. And to see a beating heart being repaired and given a second chance, and then remembering that face of the young boy in the ward earlier. These were some of the patients days after their operations, with completely new lives, children that had been unable to walk, unable to do anything, unable to attend school. Literally within days of their operations were laughing, running around. And you just realise that, you know, people talk, especially about Africa, I think, and say it's an impossible situation, a situation we can't change, we can't do anything about. And here I was seeing, literally in front of my eyes, how children could be given a life, that they could return to their homes with big smiling faces and carry on. And I think that's a real testament to the work that's done there, but also testament to the desperation of how small it is compared to the size of the continent. And maybe you'd like to talk a little bit about some of the actual specific problems that cause the heart problems in Sudan.
Well, Sudan is no different from most African countries. Rheumatic fever is the biggest killer in Africa in cardiovascular diseases. And now, very recently, there was a report by WHO saying that cardiovascular diseases will be the leading cause of death in Africa within very few years. After years and years of talking about HIV and communicable diseases, you know, for NGOs this means a lot, because for years and years it was enough that to write a project, doesn't matter which one, but if the word HIV was in it, was like triggering a slot machine. Money would pour. We have not done that, but now more and more people start to realize that non-communicable diseases are equally important, if not even more important, because of the magnitude of the problem. Just to give you a few figures, probably not very accurate, but There are about 20 million people in Africa who have the disease called rheumatic heart disease. It is caused by a stupid bacteria, Streptococcus, that gets through your throat. And as an old French surgeon from 200 years ago used to say, the bacteria enters by the gorge, licks the joints and bites the heart. Because that bacteria has a special affinity for heart valves and destroys the heart valves. And when the heart valves are destroyed, the pump cannot function anymore properly. And this causes about 300,000 deaths every year and more than 2 million hospitalizations every year. We are talking about a young population, very young. The youngest patient I've operated with rheumatic heart disease was 3 years. And the average of our patients are 14, 15, I mean kids or teenagers. So it's a disease that is compromising and putting at risk the future of an entire generation. And it's a disease that is clearly linked to poverty. Rheumatic heart disease is a disease of poverty. It would be enough to have a health system in Africa that can provide a stupid, simple prophylaxis, one injection. Every time a young kid has sore throat, and the disease would disappear probably, as it has disappeared in Europe. I mean, 50, 60 years ago, the disease was very, very important in Italy, and I presume it was the same in the UK. Now we see it only in patients who are new immigrants. And this accounts for 65–70% of our job. Most of the patients are patients affected by rheumatic heart disease. Then you have all the congenital heart diseases. In both groups, there is one common element. The fact is that they do come to our observation too late, because they have nowhere else to go, and people, they go and look for a doctor when they're very, very sick, which complicates a lot even the surgical work. I mean, to correct a congenital defect when the kid is 6 months or a year old is much, much easier than to do the same operation when you're dealing with a teenager 10, 15 years. And this is a big challenge. At the Salon Center, we could do 6 open heart surgeries a day. We could even do something more. The structure is there. I mean, the problem is that cardiac surgery, although obviously there is no profit into our job, still it is quite expensive because of all the consumable and disposable material that you are forced to use. So at a certain point we were running out of money, and we had to decrease the number of operations, and that was one of the most sad experiences I had in the last few years, you know, to give up saving lives because you have no money. This for every human being, I think, should pose serious questions, because when money becomes the determinant of life, it means that we are in a bad situation.
I should say that this was pretty much the last picture I took of a sort of humanitarian nature before I was injured, and this is Wedi and Unis, who had their heart surgery just, I think, a couple of days. Yeah.
Why not?
Just a couple of days before, and to see them up, and they were just getting their energy back, and they followed me around the hospital the whole time. Actually drove me slightly crazy because they wouldn't stop singing, and they would sort of come and get me in the morning and sing and sing and sing. But they really, their sort of smiling faces really stuck with me. And a few months after, was about a year after my injury, I went to Kenya to try out my new legs in a sort of dusty environment before going back to Afghanistan. And when I was there, I kind of had this memory that Wedi and Eunice were in Kenya. So me and my partner Jen, we tracked them down. It was a sort of 4-hour drive out into the middle of nowhere, and I think Jen was less than convinced that these kids would be there, but I was like, no, I'm sure, and I had a little scrap of paper with the name of this place. But we got there, and it was sort of an orphanage, and also kids that the parents could look after them were staying there. And they were all singing, and it was a really special moment. And then the kids that were all singing kind of stepped apart, and there was a young girl there wearing a really pretty dress, and I didn't recognise her, and she had flowers, and she walked over, and she remembered me from Sudan, and that was one of these girls. And you know, for me, often the work I do, you don't get to see what happens to the people afterwards. And it was a special moment for me, but I think more than that, it just made me realise the importance of the surgery that's done by emergency there. Because I saw this girl now living a great life with her friends, going to school. She has a complete life that she would not have had without that one hospital. It's not a case of, you know, there are other places, or literally one place making that much difference to people's lives. And you know, I'm a big believer. People often say, well, the situation's too big, the situation's too much, we can't make a difference. But I just believe you start with individuals, you start with individual cases. And it was evidence to me that the work of all these NGOs is so important, because I saw that smiling face and I just thought whatever it cost to have done that life was worth it. I'm going to move on a little bit to Afghanistan, because obviously a lot of emergencies work is connected with wars, and obviously Afghanistan is something that is very much the focus of the news at the moment. I went there last year, went back there to take photographs of the civilians injured in the war, and spent a lot of that time at the emergency hospital in Kabul. One of the things that really shocked me, one of the reasons I wanted to do that story, was that in the 10 years of Western forces being in Afghanistan, in that whole period of so-called nation building, we haven't built one functioning hospital. Now, I'm a photographer, so I'm probably going to get all my numbers mixed up, but as far as I understand it, that hospital in Kabul runs on about €3 million a year, which is roughly the equivalent of 3 American soldiers being based in Afghanistan for a year. And you think of the hundreds of thousands, millions, billions that have been spent on the military, and you think of that small fraction that's kept the hospital running in Kabul, and you question what would have happened if that money had been put to better use throughout the war. I'm just going to run through a few of the pictures that I took there. Again, what really struck me, in the same way that I was struck when I was in Sudan, was here was a hospital operating, bringing in all these patients, and you kept thinking, if this didn't exist, if emergency didn't exist, there would be nowhere for these people to go. And that's a really terrifying thing, and one of the reasons why I personally am a big supporter of emergency. This was a young boy that had been caught in a crossfire. And I think maybe a good sort of typical story of probably one of the big problems you have there, the fact that it had taken, I think, nearly 20 hours for him to actually reach any kind of medical treatment, because there isn't the infrastructure to get people to hospitals. People are often terrified if they're caught in the fighting. You know, this kid had been stuck in his aunt's house when the fighting had taken place, and a bullet had come through the building and gone through his cheek, and he had to lie there with his aunt, unable to even leave the house for hours and hours and hours before he was able to get to the emergency hospital. Here's a patient in traction. I want to talk a little bit about this boy, Sedakola. Sedakola, one of the bravest, cockiest kids I've ever met. Complete honour to meet him. But he had picked up something that had gone off in his hands, and I'm going to get Gino to talk a little bit more about that in a minute. But seeing him there, this kind of young, innocent boy, with his hands erect, because of the wreckage of war that's been left in the country. He wasn't even caught in the fighting or anything, but just the debris that's there and will continue to be there for years and years and years. Really sort of struck home with me. This is him in surgery. I would say it's kind of funny. As I say, Sedekola was a very special little kid, and at the end, I'd taken some other portraits of him, some quite nice portraits against a white background, and you know, I said to him, "Would you like a copy of one of these pictures to take home?" Of course, he was like, "Yes, I would love that." So we managed to find a way to print out this little picture of him against this white background. And I gave it to him, thinking, well, he's going to be really excited by this, and you can see the look of disappointment on his face. I was going, "Don't you like the picture?" And he's like, "I want the pictures of me in surgery." Being a young boy, I think he just wanted to go back and show all his friends, "Look, this is me in surgery with my hands like this." But I mean, maybe you'd like to talk a little bit about the risk, because again, you know, you were talking about with the heart disease, it's the poor, and again in Afghanistan, it's traditionally the poor that suffer from these injuries because they're often out collecting firewood. Again, that's why children are often injured more, because they're the ones sent out into the fields to collect firewood, etc. I mean, you might mention, I'm sure, your book, The Green Parrots, which is one of the most insidious sort of things. But yeah, I'll let you...
Well, I've done surgery for landmine victims for many years, and last time was 6 months ago. I was in Lashkargah in Afghanistan, and still after all these years, I mean, it's a big nonsense to see people torn apart by these weapons that are weapons without a target. You just throw them in the ground, and someone will step or will pick them up. Or it's pure cruelty. It's absolutely insane. And when you think that this has been done by the so-called most civilized countries in the world, including Italy, that was one of the top producers, it's all very sad. I would say that probably one of the best things that Emergency did in its short life was to run in Italy the campaign to ban landmines. And fortunately, it was a very successful campaign. Italy at that time, I'm talking about 20 years ago, was one of the world top 3 producers of landmines, and exporters, of course, because you're not going to use them in your country. And fortunately, we were able to mobilize the public opinion, and it took 6 months to pass a moratorium on the use of landmines, and then a definitive ban on landmines. But still, for the next decades, we will have to deal with this problem. And there are very small funds available to help the victims. And this is another problem that is a very serious one. I mean, the war destroys a lot, and then reconstruction is nearly impossible. You were mentioning Afghanistan. I tell you something, that we have a big dream to start establishing centers of excellence in different medical disciplines in Africa, taking the Salam Center as the model. The second center will start construction, at least, hopefully beginning of next year, and it will be a center of excellence in pediatric surgery in Uganda. We have designed 10 of these centers together with the health authorities of 10 African countries in different specialties. I mean, from trauma to pediatrics to obstetrics and gynecology to cancer. There's not one hospital that treats cancers in Africa. This is a crime. And let's take the Salam Center as a model. Construction, equipment, and 3 years running cost of 10 centers of excellence, equals 1 day of war in Afghanistan in terms of money. 1 day. Should they take a day off? After 12 years they are fighting and exporting democracy. We would have 10 centers of excellence. Should they take holidays, 3 weeks? I mean, most Europeans would go and receive medical treatment in Afghanistan because there would be fantastic hospitals. But obviously the human brain is not yet developed to that limit. To me, it's as simple as that. I see no other explanation. You see, now I read in a newspaper a few days back that now they started negotiating the U.S. with the Taliban. Negotiating because, they want a smooth, shall I call it handover? I said, come on, 12 years of war, billions and billions of dollars spent, and now, presently, Taliban probably control 75–80% of the Afghan territory, and you are negotiating with them conditions and terms of your withdrawal. All this.
Actually, I wanted to ask you about that. For those who are not familiar, and again, I will get my facts and history probably slightly wrong, but Emergency had a hospital that was running under Taliban rule in Kabul. I certainly think many people in this country, it's myself included, often get the impression that the Taliban is a force that you cannot negotiate with, you cannot talk to, that you cannot deal with. Now, as Gino says, we are suddenly negotiating with this crazy, force that apparently there was no reason with them. Now we find that we can talk to them. I think, looking back at the beginning of the conflict, would you think negotiation at that point, or if things could have been done in a different way? I read something that an interview you did actually at that time, where you pretty much predicted the outcome of what would happen over the coming years, that actually it would increase the fundamentalism, it would increase the hatred towards the West, and that it wouldn't succeed. And I just think it'd be interesting, maybe, that your experience. I know that you were connected with the Northern Alliance for a while.
Yeah, actually, the first hospital we established was in the Panjshir Valley. I happened to be a very close personal friend of Commander Massoud. And I must say that in 2000, actually the end of '99, I went to see Massoud an evening and said, listen, we feel like we need a hospital on the other side of the front line, on the Taliban side. And he was very supportive of this idea. He said, for us, to show practically our neutrality, much better to have two hospitals. And he agreed, and he supported the idea. And in fact, we were able to exchange patients that happened to get injured on the wrong side, let's say. So Taliban fighters injured and then taken to the Panjshir hospital, or Mujahideen taken to the Kabul hospital. And we were able to exchange them and return them back to their houses. This means talking to people. I've met Talibans who were absolutely nuts. I met people very reasonable, as in every society. I think it's a concept that is so simple. Just look at the list of the Italian prime ministers, and it's obvious. Talking instead of pulling the trigger is a much better option. Also because you can change things. Despite everything that's been said or written, in 2000, 45% of our personnel, national personnel, in the Kabul hospital were females. So it's not true that females could not work. Yes, it's true that most of the Taliban, they are a bit psychopaths about this issue. I had a big discussion before the opening of the hospital with the Minister of Health, who came to visit the hospital still under construction, and said, oh, but you need 2 surgical blocks, one for men, one for females. I said, how can we do that? I didn't want to start talking about the principles. I said, listen, but do you have female staff trained enough to attend the surgical operation? No. No, but the staff can be the same. So the staff can be the same, but we need 2 different buildings. So what was the problem? It's because women, I don't know, they make the operating room dirty. What was the reason? It took about 3-4 days, a couple of meetings, and about 6 or 7 liters of tea. But eventually he agreed that, okay, the OT rooms could be only 1. And they agreed also, obviously, I used the excuse of security, that women, when they entered the hospital, they had to remove their burqa. Because just say, no, how can I be sure there's a woman underneath? I mean. So when you start talking to people and they get to know you and they see that you are doing something good for their people and not killing them, at the end you can gain something. The most fantastic experience, in my opinion, has been when we decided to open a maternity hospital in the Panjshir Valley. You know, despite of what has been passed through the press in Europe, the burqa is not a Taliban invention. Today, if you go to Panjshir Valley, where Taliban's never entered, 90% of the women wear burqa, maybe 95. So when we decided to open this maternity hospital, everybody was saying, come on, no one woman will come to deliver in your hospital, husbands will prevent the women to come, and so on and so on. But we insisted, and we insisted also training young nurses as midwives and so on. And now that hospital does 4,000 deliveries a year, and they do come from Kabul and from other provinces to deliver there, because it's a clean hospital, well equipped, with surgeons present 24/7, so whatever you need is there. And this has changed somehow. Maybe not the culture, but at least a few things are much more tolerated than they were 10 or 15 years ago. And that, I think, has been a great achievement. It was not something, great job from emergency. It's just that if you go in the right direction, things happen. If you go in the wrong direction, they don't.
One of the things that really sort of struck me in Kabul is that one thing that really moved me when I first got there actually was the hospital in Kabul used to be a kindergarten, and sort of walking around you can see the sort of the basic structure of how it used to be a kindergarten. And there in one of the grassed areas is a memorial. There's some old sort of slides and play school stuff, and there's a big dip, and then a memorial saying actually that as a kindergarten a Russian missile hit it and several children had been killed while they were out there playing. And then to sort of turn around in this kindergarten and now see it as a hospital, only people that have been injured by war, by bullet, by gun or by knife are admitted to this hospital. And it's such a representation of what's happened to Afghanistan, a place that had this kindergarten, to think these children have been there playing, and now you hear in the sort of place of these children's voices, you hear the moaning of these people injured by the war, and it really represents what's happened to Afghanistan as a whole, I think. But what is really amazing about the work that Emergency does there is you meet so many people around the country who know of Emergency. They know of the work that's done there, and the huge respect given to Emergency by all sides, by all people there. There's a philosophy that no weapons are ever allowed in any of the emergency compounds anywhere in the world. there is not armed security on these doors. People would not go, I believe even Masood would leave his gun before he came in to your hospital. It's huge respect, and that respect has been built out from trust, from putting the trust. And I think, again, going back to that small amount of money that's been put into that hospital, and that has done so much more to build relationships between the West and the Afghan people. You know, you meet the Afghan people there, and you know, even though I was not connected with Emergency, but they would come up and give me a hug and me saying thank you for all the work that Emergency does. Obviously I took the credit, but they would go, thank you for the work that Emergency does. You know, this family member, this person has been saved, this person has their life back. And again, you just realise that getting back to this idea of the philosophy of Emergency, to offer this equal care for somebody in Afghanistan as you would for somebody in England or Italy, really pays off, because the people know you're showing them that respect. And I hope that in the years that are coming forward, as the military pulls out, we can encourage and you know, encourage everybody to raise as much money to keep emergency hospitals going, because that is what will rebuild the relationships that have been broken with the people of Afghanistan. I'm just going to go through the last few photographs and then we'll open it up to questions. But again, this was a young man, Muhammad Ali, that he'd been shot, and it had taken weeks and weeks and weeks before he got the treatment that was needed. And actually this is him being told that his leg would have to be amputated. And actually his father had to make the decision. And his father had said he was giving his son really a death sentence, because he said he will now not be able to marry, he will now not be able to work. And again, that's something maybe we can just touch upon, that when somebody has their leg amputated, when they lose a limb, it's a life sentence in many ways. And I know it's another thing that Emergency is very keen to do. I have a kind of saying that there is no point saving somebody's life if you do not give them their life back. And I think it's a really important thing that Emergency, again, is looking as to what happens to people when they've lost limbs, when they end up in a wheelchair. A lot of the staff at the emergency hospital actually are amputees or people that have been injured. Actually, a slight funny story, when I was there, quite a few of the staff would come up and they were interested to hear about what had happened to me, and I'd be telling them, you know, I've come back, and they were very touched. I'd come back, and they would be coming up and they would saying, you know, you've really raised our spirits by showing that you cared to come back. We're going to stop taking our antidepressants now. Be like, well, I don't know if you should suddenly. No, we're all stopping. So I was kind of slightly worried that I left the hospital, and a couple of weeks later there'd be a lot of very angry, kind of upset people. But again, you know, in that small way, you just again realise what it means for people when you show that you care, that when we show as a country that we care and we go back. And Emergency really is the embodiment of that. You know, I've worked with a lot of NGOs. You know, if you give me a couple of more drinks later, I will slag off a lot of them. Gino will do it even more.
No.
But in all seriousness, you know, I've seen a lot of, you know, some of them are effective, but many of them, the money that actually reaches the people is kind of, is not right compared to the amount of money that's at the head offices that goes to the facilitation of the staff. Emergency really gets to people and really makes a difference with the amount of money that they have. They are so incredibly cost effective. When I was injured, I knew that the next story I did would get a lot more attention because of what happened to me. It was in many ways an opportunity. I hope it says something about my feelings towards Emergency, that out of every story I possibly could do, it was Emergency that I chose to document, because I hoped that it would give them just a little bit more attention. And that really is the respect that I have for them, and I hope that everybody else will have. But yeah, I mean, I'll leave it to you to finish off, and then maybe we'll open to questions.
Yeah, no, just a comment. I mean, because you mentioned the future of people who get injured, who have to suffer amputations and so on. And you know, we have established a rehabilitation center in Iraq many years ago, and now it's still working and it's still producing 2-3 new prostheses every day, and patients are coming from all over Iraq. And this was done because we asked ourselves, where is the end of the therapy? I mean, you start in the operating room and in the emergency room when the patients arrive bleeding and shattered, and then okay, surgery went well, and so we decided to establish this center where to fit patients with prosthesis or orthosis, but also to teach them a job. And we have established workshops. I mean, they call it vocational training courses. I'm not familiar with all these things, but basically we established 6 months courses in blacksmith, carpentry, leather work and tailoring and so on. And at the end of the 6 months course, the former patients had a diploma. And we look at the map and pick up 2, 3 that were living in the same village or in nearby villages and start to establish the first cooperative. And establishing a small workshop, supporting them financially for the first 6 months until they were able to maintain themselves and their families. Today we have 340 cooperatives in Iraq, and they are all functioning. And then, you know, the one who was originally the handicapped person has become the breadwinner of the family. For me, that's the end of the therapy.
You know, I mean, it is a really important point.
Let's take it as an invitation to visit the center.
Yeah. No, it's you know, for me, when I was injured, in many ways, it was actually after the initial few months, and when I was in a wheelchair, and I was told I wouldn't probably walk again, that really I hit my lowest point. And really, at that point, I had survived all the operations, 30-something operations, and you know, to a lot of people they thought the worst was over, but to me the worst really was then, because I thought, what is my life now? What future do I have? And I was lucky. I had incredible support. I had some of the greatest sort of medical minds helping to get me walking again, the best physiotherapy you could possibly get, and I was given my life back. And one of the things that really struck me in Afghanistan was meeting people that are not given that opportunity. Their lives are saved, but they're not given their life back. And again, it's something that I think as a country really, we have a certain responsibility as a nation that was involved in the fighting there, to think about the people that are left there. I think of that lowest point that I was at that point when I was suicidal, and I think of the tens of thousands of people that have been left at that point, at that almost point of torture. And I feel that it's our duty to try and support people like Emergency, to try and make a difference to those people's lives. So we're opening to questions now?
Very much. Sure.
Hi. I have a question in relation to the disease that you said is related to a bacteria. Is there any sort of test, rapid test that you can do in small health centers in rural area which could detect this disease and then being able to do a case management, to follow that patient and to treat him, and just to avoid this 60 or 70% of the population that you said is in need of a surgery? Is something possible?
Oh yeah, there's something very possible and very simple. Is primary prophylaxis. I mean, if a kid who has strep throat, sore throat, gets one ampoule of penicillin or ampicillin, because penicillin is a bit painful intramuscularly, it's finished. The bacteria will never attach the heart valves. But this is what happens in Europe. When a mother sees a kid starts coughing and say, "Oh, I have pain here, I cannot swallow properly," and so on. The day after, the kid is taken to the pediatrician or a doctor who gives a shot of antibiotics, and that's it. That's the end of the story. The problem is that in Africa you don't have this infrastructure, medical infrastructure at the level of the villages.
I'm asking this because I was thinking about is something that could be included into the surveillance system of a country. I work on neglected tropical diseases, and I'm trying to figure out if we can set up a surveillance system in many countries where I work. And, to know that there is a disease which implies such a high, need of surgeries for something that can be detected so easily, and where you can just give an antibiotics and then it would save the life of this person. Is this something that could be included into a routine surveillance system in a small rural areas? Is something feasible? And how much, is it feasible in the future, in the long run, when you set up a surveillance system in a post-war country?
Well, I don't think personally that the best solution is a sort of mass prophylaxis. And it's difficult to do it anyhow in a country where you have no census. You don't know how many people are living in the country, how many kids. So to do that, you have to be based there, basically, which means you have to have a health infrastructure, even a small one, a small clinic. We have a good experience, for instance, in a clinic that we have in a refugee camp in the outskirts of Khartoum. I'm talking about a camp of 400,000 people. But we have a clinic in the camp, and therefore we are in the condition to monitor. And with health promoters, you can go family by family and inform them more than once, because they are not used to medicine. Medicine has never developed in Africa. So you have to teach the mothers and train the mothers and make them understanding when a symptom can be dangerous or not. But then you have to have someone who can deliver the drug properly. It's not an easy job if you're not there. I mean,
I'm just thinking that this is, as you well know, if you do a pilot study and you try to do, to establish a surveillance system that is, well monitored, and then you can convince donors that actually this is the system. You can save a certain number of lives. You can, avert certain number of cases. Then it will be, the type of study that people want to know about, and then they will be supporting for more work and possibly extend it to the national level. In many places where now, we have all this disease, we have leprosy, we have, trachoma, schistosomiasis, and all of that. And surveillance, is very much needed. So I was wondering, if there is the possibility of adding these other diseases that are extremely, damaging the life of people, and just by simply doing, surveillance system which is monitored constantly, if this can make a difference.
well, for sure, yes, in the long term. But it takes a lot of energy and efforts.
Hi, I was just curious, I don't know, I missed the beginning, how your emergency hospitals are staffed. Is it a combination of local staff or European staff? How do you staff emergency hospitals?
Well, every hospital has more or less 10% of international specialists and 90% of national doctors, nurses, technicians, and still the cleaners. This ratio is more or less constant. Obviously, the ultimate goal is to have even the Salam Center for Cardiac Surgery entirely run by Sudanese or African personnel, and that's what we are aiming at. But it's going to take another 10 years probably, because now we have started training. We have started since a few years to train properly nursing staff. All the scrub nurses in the operating rooms, for instance, are Sudanese now, and they're excellent. Most of the intensive care unit nurses are Sudanese, and they do a great job. But to train a young doctor to become an autonomous and independent cardiac surgeon, it takes time.
Takes a long time, and you're doing that training all on site in the place.
You have to train them 8 hours, 10 hours per day in the operating room.
I'll ask a quick question then, seeing there's no other hands up. Uganda, you mentioned Uganda just curiously. Is that going to be a paediatric centre or cardiac as well?
No. Pediatric surgery, but not cardiac surgery, because kids from Uganda, they do come to the Salam Center for surgery. I know it's a bit grotesque to tell patients, you go to the next country because of the type of disease you have, but we are in a situation where there's nothing. And this center will deal mostly with malformations, which are very common in the pediatric group. We'll be on the Lake Victoria. A great hospital, because we are designing it with one of the most famous world architects, Renzo Piano. And
Why have you chosen Uganda in particular?
Because Uganda was one of the 10, 12 countries that cooperated with us in trying to establish this network of African excellence, as we call it. And when we discussed with the Ministry of Health of Uganda, he identified pediatric surgery as the country priority #1. So we had also to listen to the local authorities.
How important is it having a famous architect for the new hospital?
Sorry?
You said that Renzo Piano was the new architect. Is that very important? Does that raise awareness? Does it make it a fabulous hospital?
I will tell you in a year, because so far we are still working on the design of the hospital. But well, first of all, Renzo is a friend and is a very clever person and very committed, and he got so much involved into this project because he got the point of this project. I hope it will help also in raising awareness, but by awareness, I basically mean euros, solely to be in UK, but pounds are good as well. But that's my idea of awareness, because I'm 65, and I heard a lot of people, what fantastic job, okay, help. It's amazing, when you talk to a millionaire asking to help, the most frequent answer is, let me think. Yeah, I will think to contact someone who can help you. The idea that he could be one of those someones doesn't cross his mind. So, let's hope Renzo will raise awareness.
I have to say as well, I mean, visiting, getting back to what I was saying at the beginning about the sort of philosophy of emergency and about these hospitals is stunningly beautiful, but they're also incredibly functional and sort of environmentally friendly. I mean, the Salam Center is incredible. I remember being shown around there, and the amount of innovation from solar power to all different things that are used in that. Even the way that the cooling is done using bamboos, and it's just incredible. It's a really thought out process. And again, and getting back to the other question that was earlier about whether you're training doctors and things, it's another thing that always struck me about the emergency projects. A lot of NGOs go to places, they're there when there's a crisis there, and then they leave. Emergency is very much about the sort of sustainability and staying in a place, and these hospitals are built with that sense of permanence.
Well, even now in Afghanistan, most agencies have already left. Recently, the International Committee of Red Cross has withdrawn 90% of the personnel. UN agencies are keeping the staff to a minimum. I mean, everybody is preparing for the exodus that's going to happen.
And yet, I think I'm right in saying that already the casualty figures are up by about 40% this year. So although the agencies are already starting to pull out, the actual amount of civilians being injured is already up by 40% this year.
Yeah, the number of war wounded we have received this last month compared to the previous year was 42% higher. And every month we go up. So I'm afraid next year I will have to stop for a while to do cardiac surgery and go back to Afghanistan.
Hi. If I may pull you back to the topic of ministries of health, I know that's it's notoriously a difficult area in the NGO medical space. You mentioned the Ugandan Ministry of Health. What is the state of play with the other African countries, in your opinion?
Well, there is one difficulty, that ministers of health change quite often.
Yeah.
Also because normally those ministers are not the most powerful ministers in their country. Health is quite a neglected sector. So sometimes you make an agreement with the Minister of Health, and then 3 months after you have another one. And then the problem number two, which is probably also linked to the number one, is that sometimes you find that there are people who are interested to develop profit kind of medicine. And this is not a surprise, because even international organizations or NGO believe that medicine and medical help should be based on the cost recovery principle, which in my opinion is a crime, but they believe so, and this complicates a bit the work. But in general, I must say that they are very open and very interested in serious projects. The first time we met, we called Ministers of Health to have a 3-day seminar in Venice. And the conclusion of that seminar was to write down a manifesto for a human rights-based medicine. On which principles should we organize the health systems? Which I think is very important. We don't discuss about that anymore in Europe. We discuss only about money. Instead, there's been a good experience to exchange cultural views and see that they were interested in a kind of medicine not based on profit. So I hope that if we find the resources, or if the Afghan Rambos will take a day off, we can implement this project. Inshallah, as they say.
I just wanted to say, first of all, Giles, your exaggerated emails worked. Second of all, I just wondered, you sort of touched on some people being on antidepressants, and Giles talked about his process of rehabilitation, and you talked about giving people their lives back. And I wondered if you felt there was a need for sort of psychological support for the people that you're treating.
Well, for sure there is a need, but we were not in the position to deliver it, mainly because of cultural barriers. I mean, the language barrier is tremendous. I mean, how can I understand if an Afghan patient is more depressed than another one? The maximum I can get is an English translation from an Afghan that has a vocabulary probably of 100 English words. So to be a psychiatrist or a psychologist, that is much more difficult than to be a surgeon, for sure. The problem exists, but I also believe that probably more than having, psychological counseling, it's important that from the very beginning patients find themselves in a friendly environment, in a hospital, which means hospitable environment, in a beautiful place, for instance. We are a bit maniac about gardens in our hospitals, because we believe that, if I think about some hospitals in my country, 11 stories built in cement and everywhere. I mean, they keep the windows sealed, otherwise the people would. So the environment you are in, I think, is quite relevant.
You spoke about some of the... my name is Jerry Clare. I'm an ophthalmologist in the British Army. And you spoke about some of the other NGOs that you've come across. And I think there's a tremendous scope for a bit more cohesion in the in the NGOs that have, after all, similar intentions of improving the health of those who cannot afford it and who are not in a position to pay for healthcare. And so I wonder if there's any moves to perhaps unify the approach between your organization and other NGOs, and if not, why not?
Well, I don't have an answer. I can tell you that this does not happen often, at least in the health sector, because every NGO has its own approach. I would never send an emergency team to do surgery in a filthy place, for instance. No way. Should be a hospital. I've done surgery under the tent because I had no choice in the next 6 hours. But I would not design a project to send a team to work in a hospital that does not have, minimum standards of hygiene, for instance. And this is just one example. Other NGOs will send teams or establish projects considering that patients or beneficiaries, as they are called in the NGO world, they have to contribute, to pay something. In my opinion, one that has got a bullet or has stood on a landmine has contributed already. So there's no need to ask for more. And again, there are other NGOs who are fully aware of the great need of the project in that place, and then they apply it to the European Union or to the UN. If they get the money, they establish the project. If they don't get the money, the problem doesn't exist anymore. So each one, as you know, is his own approach, and that makes it difficult to have a cohesion, as you mentioned. So another story is to cooperate. That is possible and is done.
Perhaps if there was a supra-governmental oversight of the NGOs and many organizations, that they can communicate better and have some sort of coordination.
Yeah, provided it doesn't cost 30% of all the projects, because it's not uncommon now to see a project even financed by the EU. Say the cost of the project is 1 million euros.
Yes.
40% is security. If I need security to go and help in a country, means that someone doesn't like me very much. So, better to go somewhere else.
May I ask how your organization keeps its head above water financially?
About?
May I ask how your organization is financed?
Well, 70 to 75% is a big amount of small donations. I'm talking about an average donation of 50 euros a year, more or less. So there are hundreds of thousands of people in Italy, because our funds come mostly, more than 90% from Italy, who donate a very small amount of money. And the other 25% comes either from some contribution from European Union, or very recently also from some UN agencies in Afghanistan. In certain projects, such as Sudan, for instance, there is a contribution of the local government. And now we intend to plan this as a standard. We have asked, for instance, the Ugandan government to pay for 20% of the cost of the next hospital, and they agreed. We also have some support from local institutions in Italy, cities, mayors, or provinces or regions that. But more than 2/3 are private donations. But many citizens, unfortunately, not too many rich among them. So
I have to say, it's one of the things, again, that I think makes emergency unique in many ways, is when you go to Italy, the amount of people that are aware of emergency and the amount of kind of grassroots level of support that it gets, I don't know an equivalent of any other charity that works in that way, where people do so many things within their villages, within their local communities, to raise money every year for emergency, and it's incredible actually how many people are involved in it. And I know a lot of people tend to give money over here when there's some big thing on TV, or but actually it's kind of almost part of people's life. It's a part of tradition and a part of what they do, and I think that's something that'd be great to try and get going over here, and a few millionaires.
Hello. I was wondering, given the imminent departure of NATO forces, how do you foresee emergency's role in Afghanistan? Do you think there'll be more projects coming online in Afghanistan? Can you see a sustained presence given the high profile of emergency? But also I'm assuming that you've built some kind of links with the Taliban, whatever kind of links they may be. But how do you see your role post-NATO departure? Thank you.
Well, we have links with the Taliban as much as we have with the government, in the sense that we have never refused to talk to anybody about providing health care. Politics is something that doesn't interest us as an organization. What I can say is that, first of all, that we are going to stay in Afghanistan. We're not going to withdraw, although the security situation is getting worse and worse every day. So what I can say for now is that we will have much more work to do. This is a trend that we have seen already in the past 18 months. I mean, an increasing number of wounded, not only in the areas where you would expect them, like the Helmand province, where there was a NATO bombing campaign, but also in the Panjshir Valley, that was traditionally much more quiet, and in other areas around Kabul, for instance. So for sure the number of patients is going to increase, and we will have to set up or adjust our facilities. We have opened 3 new first aid posts in the past 2 months in areas also quite close to Kabul, not only in the Helmand province, because the fighting now is it's like popcorns. Pops up like this, and probably we won't be able to establish new surgical centers, also because to build a new hospital takes 1.5 years, and there will be no time for construction for sure, and not even materials for construction. But we will have to adjust our program and expand our program in the field in order to be able to refer to the surgical centers patients safely and quickly as much as possible.
I think we've got time for one more. Anybody's got one last?
Hi, my name is Nara. I teach law in one of London universities. I don't have a question. I just want to say thank you very much to both of you. I feel very humbled to be in your presence, and you're doing something amazing and great, and it was simply very humbling to hear your stories and be in your presence, and I would like to say thank you very much.
Thank you.
I just wanted to say one final thing. Actually, I read that email at the beginning. I didn't read the next bit where I was saying that I was going to go and meet Gino at his house for dinner. What shirt should I wear? And I got the reply back going, "What is this? Some kind of mandate?" But what it was is that I've met a lot of incredible people in my life. You know, I used to be a photographer that photographed the famous, of all sorts, from music to whatever. I've worked in a lot of conflict areas and met some incredible people. But for me, you know, Gino really, somebody who's given so much and really made a difference. I was very humbled to meet him. I remember as well, at various points in my career, I would think, well, what can I do as just a simple photographer when you meet people like Gino who are doing so much? And sometimes I think, well, I'm just wasting my time because I can't make any of the kind of impact that someone like Gino can. But I can't. But I can make some small impact and some small difference. By doing the work I do, maybe I've got a few people here this evening that have heard the work of Emergency. And I just hope that rather than just walking away from this and thinking, oh, that was interesting, I just hope that you go back and realise that every one of you can make some small difference, whether it be to write to an MP to talk about what's going on there, if you work in the medical profession, to maybe think about volunteering or tell other people about the opportunities of working with Emergency. It could be just setting up a cake sale and raising a few pounds to send to Emergency to help them keep doing their incredible work. I feel very honoured to have been here this evening, and I'd just like to thank everybody, Gino, and everyone from Emergency that's come here tonight. Thank you.
Thank you.